Good afternoon, everyone, and thank you so much for having me speak today. No matter how often you practice, sometimes things just never go the way you intend them to. Kevin and Rachel, thank you so much for the kind introductions. Today I'm going to try my best to provide some understanding of what we know about the epidemiology of AFM using the past 6 years of our accumulated AFM surveillance data. Okay, hopefully this is okay. So before I begin, I wanted to take a step back and talk for a minute about the purpose of collecting surveillance data for AFM and how we go about ensuring, as much as possible, the integrity of the data we collect. Conducting surveillance for AFM is challenging, primarily because there's no laboratory test for AFM. Many illnesses, like influenza, have a laboratory test that helps define the condition. So for example, if we see somebody with symptoms like cough and fever, and they test positive in a laboratory for influenza virus, we can say with some certainty that they are a case of influenza. But AFM is different. Although we believe that enteroviruses, and in particular EVD68, play a role in causing AFM, many cases test negative for these viruses. For AFM, we had to create a different system for gathering data and collecting cases. And understanding what medical information we needed to classify those cases. For our surveillance system, we decided medical records and MRI images would be the best proxy in order to make case classifications. In creating the AFM surveillance system, we developed case definitions to ensure that we collect standardized information from year to year so that we can compare cases across time. These case definitions have changed slightly since surveillance started in 2014. It seems like we learn something new every year after an outbreak. But the definition of a confirmed case has stayed consistent, and it is still the acute onset of flaccid limb weakness and an MRI showing a spinal cord lesion largely restricted to gray matter and spanning one or more spinal segments. The source of CDC surveillance data for AFM is via health departments from the reporting clinician. Once a clinician suspects that a patient may have AFM, they report to the health department. The health department then assists in the collection of medical information and biological specimens to send to CDC. CDC then works with an expert panel of neurologists to review the information, look at the MRI images, and provide a case classification. The surveillance case classification is then communicated back to the health department and from there to the patient and clinician. Public health surveillance for AFM serves a different purpose than making a diagnosis. And I know Kevin mentioned this, but I wanted to go into it in a little more detail. I want to emphasize that the CDC case classification for a suspected case of AFM should never replace or take precedence over the clinical diagnosis. Clinical diagnosis is used for patient-level, individual clinical management decisions, and it's time-sensitive. A diagnosis is made based on full information, the clinical history, examination, and diagnostic testing. It aims to be as accurate as possible to provide the best care and treatment for that individual. But public health surveillance, on the other hand, is conducted at the population level. Standardization using case definition helps to measure disease burden and trends over time. Surveillance is delayed due to reporting lags and the time it takes for the case classification. And finally, it has to balance the sensitivity, making sure that we cast a wide net for all possible cases with sensitivity, making sure that those cases fit into a certain mold, like a cookie cutter, so that they can be compared to each other. And we certainly hope that as we advance our understanding of AFM and biological markers that predict it, cases will become more straightforward to classify. So with that as an introduction, what does epidemiology tell us about AFM? Some details are apparent just by looking at the number of confirmed cases by each year of surveillance, shown on this graph called an epidemiologic curve or epicurve. You can clearly see the every other year peaks in AFM cases beginning in 2014. You can also see that most cases occur in the late summer or early fall. In fact, 85% of our cases occur between August and November in those peak years. Also, one can note that confirmed cases do appear to be increasing every other year, starting with 120 in 2014 and reaching a high of 238 in 2018. Although national case reporting for AFM didn't begin until 2014, when we look back to years prior to see if we can find AFM cases, we see only small numbers. An assessment was done at 5 pediatric academic centers that looked at MRI images from 2005 through 2014. And results show that the number of AFM cases found in 2014 was about 3 to 4-fold higher than in the previous years. These data suggest that the epidemiology of AFM shifted during or slightly before 2014, likely reflecting a changing or emerging cause. We know that AFM has multiple causes, including infections like enteroviruses and flaviviruses, and other causes such as neuroinflammatory conditions or spinal-vascular disease that share similar clinical and radiographic findings. Not everyone who is infected with these viruses will develop AFM, and not everyone with these other conditions will develop AFM. But all of these things can and do produce the clinical and radiographic findings we call AFM. Surveillance data suggests that a consistent low-level baseline rate of AFM, highlighted here by the red box, which is regular from year to year, and it's likely caused by a mixture of infectious and other conditions that I've just mentioned. We believe this low-level baseline has probably been the pattern for decades, but clearly something has changed in 2014. And that is the question. What is causing these new peaks in AFM? Because 2018 was our most recent peak year for AFM, these data for AFM cases I'm about to show you are taken from an analysis that was done of the 238 cases that CDC confirmed in 2018. Cases come from 42 states. The median age is 5.3 years, and 94% of our cases are pediatric, meaning less than 18 years. 58% are male, and 53% identify as white, 20% as Hispanic, 9% Black, and 4% as Asian. The state map shows a scattered distribution of confirmed cases across those 42 states without any geographic clustering. Although California and Texas have more absolute case numbers, if we calculate the incidence, which is number of new cases per pediatric population, it's no greater than in any other state. 98% of cases are hospitalized, and 54% are placed in the ICU, either for monitoring or for respiratory support, as paralysis can progress rapidly. 87% of cases have signs of inflammation in the spinal cord, with a higher than expected white blood cell count found in the cerebral spinal fluid, or CSF. There's a median of 94 cells and a lymphocyte predominance. Limbs affected are variable. Over a third present with one affected limb, and about a quarter present with all 4 limbs affected. And we know there's a predilection for upper extremities. 47% of cases have only upper extremities affected, and 16% have only lower extremities affected. As Kevin mentioned, most children present, and Rachel as well, most children present with an illness about 1 week before limb weakness onset. The proportion of cases affected by each symptom is shown by the blue horizontal bars on the left, and the time from that symptom to limb weakness onset is shown by the light blue bars on the right, with the median or average time of onset in the blue circles. 97% of AFM cases had some combination of symptoms consistent with a viral illness before limb weakness onset. 80% had upper respiratory symptoms, 77% had fever, 46% had neck or back pain, and 22% had a gastrointestinal or GI illness. What's interesting to note is the timing of these symptoms. AFM patients generally present with an upper respiratory illness like cough or runny nose, and then develop fever and back pain just slightly before weakness onset. One possibility, one reason why this might occur is because the virus is replicating in the upper respiratory tract, causing those initial symptoms, and then it gets transported back to the spine where it causes that fever and back pain due to inflammation. Weakness shortly develops afterwards, and most commonly in the upper limbs. The challenge remains that routine diagnostic testing of CSF and other specimens has been low yield. This slide illustrates the CDC testing results for 2018. Each horizontal bar represents a different specimen type, and the colors indicate the types of enteroviruses detected. EBD68 is in yellow, EVA71 in blue, and other enterorhinoviruses are shown in purple. Negative specimens are highlighted in gray. And so as you can see, for 2018, only 2 CSF specimens tested at CDC were positive, one for EBD68 and one for EVA71. Stool pathogens were the usual mixture of enteroviruses and parechoviruses. In 2018, we had 44% of respiratory specimens that tested positive and 30% tested positive for EBD68. But overall, less than half of the specimens tested were positive for an enterovirus. So because so few specimens are positive, it's hard to be conclusive about what is causing AFM in these peak years. If there is one major cause for AFM in peak years, however, we thought that cases in peak years should look different than cases in non-peak years, which we think have multiple different causes associated. So we compared cases in 2016 and 2018, our 2 peak years for which we had complete data, with cases from 2015 and 2017, our non-peak years, and looked for differences. And interestingly, peak year cases do appear different. They are significantly more likely to have high white blood cell counts in the CSF, a greater proportion of upper limbs only affected, a greater proportion have a preceding respiratory illness prior to limb weakness onset, and more cases in peak years have enterovirus or rhinovirus isolated from any specimen. Interestingly, only cases in peak years tested positive for EBD68. In contrast, cases in non-peak years were significantly more likely to have lower limbs only affected, be more severe, and be older than cases in peak years. We defined a case as severe if they had weakness in all 4 extremities, had cranial nerve involvement, and required mechanical ventilation. However, when comparing the 2 peak years, 2016 and 2018, there were still significant differences. Cases in 2016 were more severe, had more cranial nerve involvement than cases in 2018, and also had a higher proportion of specimens testing positive for EBD68. Cases in 2018 were more likely to report fever and respiratory or gastrointestinal symptoms before weakness onset. There were also more cases with specimens positive for EVA71 in 2018, which was due to an outbreak in Colorado. So in summary, AFM surveillance data, including laboratory data, gives us answers, but it also highlights remaining questions. These data suggest that causes of AFM in peak years appear to be different from those in non-peak years, but that even during peak years, differences may suggest more than one cause. In combination with other recent studies, data point to enteroviruses, and EBD68 in particular, as the primary cause of AFM in the United States since 2014, and the trigger of those seasonal every other year peaks. But that outbreak of EVA71 in 2018 reminds us that many enteroviruses have the capability to cause AFM, and that we should continue to do surveillance broadly, both clinical and laboratory, to help us understand the full spectrum of the causes of AFM. And whether it be a single or multiple causes of AFM during these peak years, the underlying mechanism for the development of AFM remains the critical unknown. If EBD68 is the primary driver in peak years, why does the common virus cause paralysis in smaller numbers? And do these differences in case characteristics in peak years give us a clue about disease mechanism? Understanding the disease mechanisms of AFM will allow for treatment and prevention messages moving forward. So the question we're all asking ourselves is whether we'll see another increase in AFM this fall. Social distancing and hygiene measures that have been adopted widely across the country may affect the circulation of respiratory viruses, including enteroviruses, this summer. If so, cases may not occur at all, or they may be less than expected. We're uncertain about the future, but we're certainly prepared. We track AFM activity by the number of reports of suspected cases that we receive from health departments. Keep in mind, these aren't confirmed cases like we're shown in the epi curves, but reports of suspected cases sent to CDC for classification. This is as close as we get to real-time activity tracking. Peak year report averages are highlighted here in blue by weeks of the year. And our non-peak years are shown in yellow. Right now, our current reports are shown in red, and we're at the expected baseline for this time of the year, even slightly below. We remain vigilant for an increase, and we certainly are prepared to respond to an increase. This summer, in conjunction with many of you, we have planned a multitude of communication activities to increase awareness across the spectrum of providers who may come into contact with AFM patients, from those early providers in emergency and urgent care through to rehabilitation experts. AFM remains a CDC priority, and we certainly appreciate the collaboration across everyone listening here today to this symposium as we work together to bring answers to families and patients. So thank you very much. I will just quickly acknowledge all of the people on this slide that made the data that I presented today possible. And with that, I'd like to turn it over to my colleague, Dr. Charles Chu, to discuss in more detail the viruses involved in AFM. Thank you very much.